Welcome to this episode of Cancast. I'm here with the fabulous Dr Blake Pearson, who's a Canadian family medicine doctor and founder of Greenly Med and a prescribing doctor of cannabis. Thank you so much for joining me, Blake. It's good to see you. That's a strong hat.
Yes. Well, here in Canada, it's still quite chilly. Yeah.
Is it?
Yeah. So I'm still.
What's the temperature?
Last night it dipped down below freezing.
Oh.
Yeah. So now we're in this kind of part of the year where last week it was 20 degrees. It was beautiful. And then last night there was snow. So it's a bit messy.
I mean, it sounds a bit British, to be honest. It can't make its mind up here either.
Yeah, exactly.
Cool. So you're a doctor and you prescribe cannabis. So can you tell us a little bit about that? Like, how did you first become interested in cannabis as medicine? And as a doctor, were you skeptical at first?
So yeah, like we're kind of trained to be skeptical.
Mm-hmm.
It's part of our nature. But for me, I got started, family medicine, regular GP, had a practice in a family health team, which here in Canada, group of physicians, dietitians, occupational therapists, counseling, all under one roof. And that was, where I got started. And then I started to treat some of my own patients with cannabis. And when I say that, it's not kind of, for anyone who's new to cannabinoid medicine, sure, you can inhale cannabinoids, but we use a lot of the oils, the capsules, so kind of exact dosing. And I have a big senior patient population. So we were using primarily high CBD or balanced formulations, but with my own patients, starting out with chronic pain disorders. So if you think seniors, osteoarthritis, degenerative disc disease, spinal stenosis, fibromyalgia, those kinds of things. And really, it was kind of organic. So started to see my patients, saw some positive outcomes when other medications had failed. Think like your gabapentins or your pregabalins, things like that. Sure, things I'm sure you're familiar with.
Trying not to let it show on my face, but yeah.
Yeah. And then, of course, the other things too, right? Even that's kind of one class, but even the more potent analgesics, so your opiates, your fentanyl patches, your Percocet, your hydromorphones, those things. But anyway, so started with my own patients, saw some benefits, then really dove into learning more about the endocannabinoid system, going to different conferences, really educating myself. And then after seeing my own patients, I started to take referrals from some of my colleagues. And then it really went from there where it became my full practice, and really interesting because it became this practice where it's very diverse. So now, yes, there was the chronic pain patients and those diagnoses I'd mentioned, but then once I got more comfortable and put it into practice, then obviously sleep disorders became very important. Mental health, with everything that's going on with the pandemic, very important. And you can use cannabinoid medicine for certain diagnoses in that realm. And then something that's real passionate to me became the work I do in elder care or long-term care, and working with dementia residents using cannabinoids to reduce the responsive behaviors, so the agitation, the calling out, the wandering the halls, where traditionally they'd be given these antipsychotics, which are harmful, side effect of increased death risk, kind of a bad side effect. So really, it morphed into this really interesting practice, again, with the dementia residents, and now even with same idea with kiddos with rare or severe autism that self-harm, or developmental delay kiddos that self-harm, using cannabinoids to reduce those behaviors, again, as opposed to these harmful antipsychotics. So that was a lot, but that's kind of what I do.
Well, they're kind of, I suppose they're two sort of cohorts, aren't they? But I suppose what's happening in the body is very similar, isn't it? You sort of just calming their sort of agitation, their central nervous system, with something that I suppose, I don't know, have you seen that there is a less side effect in terms of side effect profile with those against things like barbiturates, antipsychotics?
Yeah. So when
Yeah,
you compare those classes of medications, certainly the side effect profile of cannabinoid-based medicines are favorable, especially as it relates to, if we're talking about CBD formulations, very well tolerated. And that's a key distinction for people too. Like a lot of times GPs and other specialists will kind of lump cannabis as this broad topic, but
yeah.
it is important to kind of drill down on what are we actually using? What are the ratios of THC to CBD? Because they do carry different side effect profiles. Um,
Cool.
yeah, and then other docs might be kind of hesitant with the THC formulations for fear of side effects. But even that particular class, when you dose it low and go slow, very rarely do you see any kind of serious adverse effects. You might see some dry mouth or some fatigue, but really they're pretty mild as far as side effects.
Totally. And we suppose we're still learning as well in terms of the different cannabinoids. Like, I suppose there's been more research done on CBD and THC and possibly CBG and CBN, but we're still learning, aren't we? Like what the possible applications could be for preventing and sort of stalling illness as well as treating sort of after
Yeah,
the fact, aren't we? Things like THCA and juicing and things like that, which are sort of
yeah,
becoming a little bit more popular as far as researchers looking at them, which is it's really exciting. And you're right when you're saying that people look at this as cannabis. It's a one thing. It's cannabis. It's not. It's like a whole library of possible medicines, as far as I see it, that you
yeah.
can sort of mix and match and play around with, and also select depending on what symptom you're experiencing.
Yeah, and that's why, as a clinician in this area, it really is enjoyable because that art of medicine comes back. It's not just cookie cutter, here's the guidelines. There's working with the patient, listening to them, trying something, adjusting. So as a practice, it's quite enjoyable.
That's kind of more of a holistic approach, isn't it? I suppose that's more how, like, sort of the ancient way, and I suppose the way that herbalists still operate. And I think it's a different mindset, isn't it, to your standard 30 milligrams of duloxetine or 15 micrograms of fentanyl. It's like a very different to then say, okay, so I've got flexibility within this medicine
Yeah,
at,
yeah,
at its profile, at its terpene profile, at its extraction method, at its dose. So, the flexibility is massive. So try as a doctor to try and get your head around something that's actually inherently black and white in the way that they've been trained pharmaceutically, to then adapt to a more holistic approach. I think that's I think that's going to be problematic for some people. You seem to have really embraced it.
yeah. I embrace it, and the reality is though it can be overwhelming, and certainly when you're talking with physicians and working with physicians, and of course I train physicians here in Canada, Australia, Germany. It's kind of two dialogues, because that is the interesting thing is the different cannabinoids, the terpenes, and the art. But when you are talking about where's the evidence and in getting potentially a physician to kind of turn on to thinking about cannabinoids, really you don't want to kind of overwhelm with all the possibilities. Really what's important, and I practice this way too, where I'm certainly intrigued with CBN, CBG, different terpene compositions, but really the evidence at the moment surrounds
Yeah.
THC, CBD, the path or the physiology, how they work, the different mechanisms, the different receptors, the conditions where there's evidence, and that's a good starting place. And certainly when I'm working with other docs, we're focusing on, okay, when to use high CBD, when to use balanced oils, and getting comfortable dipping the toes in the water, as opposed to kind of this
Yeah,
kind of
it's
broad.
overwhelming, isn't it?
Yeah,
And I think that's a bit of an issue when patients walk into clinic and they know all of the lingo, and they're like, they walk into a doctor who's just writing pharmaceutical prescriptions all day every day, and they give them this complete overwhelming sort of a bit
yeah,
of information, and it just goes right over the head because they don't have the base knowledge. It's the base knowledge, I think, that's lacking in the UK and probably still in some areas in Canada.
Yes, definitely. So although we have, a number of colleagues here that we're certainly passionate about cannabinoid medicine, um, but it still isn't the norm here by any means. I think I was reading still about 90 to 95% of physicians and nurse practitioners still haven't written a prescription for a cannabis-based medicine. So yes, we kind of are ahead of the game here compared to the UK. There's still a lot of room for growth, and again, that's something that I'm very passionate about, is educating and getting other practitioners to start, because once they do, and once we're working together, I've yet to see any physician or nurse practitioner say, geez, I haven't found this useful, if they've actually put it into practice, not just with one patient, but if they've treated 10, maybe 20, there's nobody that has thrown it out of their toolkit. It becomes a very valuable part of their practice once they start.
Yeah. Yeah, no, that makes sense.
Mm.
And I think, there's more and more, I suppose this is relatively new to the UK, in the fact that we do have an overwhelming sort of opiate issue. In the States
Yeah.
and Canada, obviously, there's been a bit more awareness of that for a few years, but I think that...
And still ongoing here, like it kind
Yeah.
of got swept under the rug with
Did it?
COVID. And I was reading an article just the other day where our stats are not even flatlining, like they are still going up, and it's a real issue.
Wow. Wow. I
Mhm.
mean, what's happening here in the UK is that NICE, who are our like governing body, so they decide what medicines they're going to recommend that the NHS prescribe for certain things. So they were the ones that said there isn't enough evidence for cannabis, for example. So they
Which
just...
is always an interesting
Yeah.
statement, because it's kind of this like catch-22 where there is certainly evidence. There's
Yeah.
plenty of evidence. It's just not kind of the traditional large RCT, and it'll never happen because nobody owns THC or CBD, so no one's going to spend that kind of money to do those kind of trials.
Exactly. And I just think RCTs, when you're talking, I mean, RCTs are fine if you're talking about single compound medicines, but
Sure.
when you're talking about cannabis, which has variations, and where do you even start? Four and a
Yeah.
half thousand strains, 3 years per RCT. I mean, you'll have it done. It'll be, we'll all be long dead by the time we've got the evidence for that, and nobody's paying for it, are they? So it's just like trying to fit a car into a cereal bowl. RCTs for cannabis, it's
Yeah.
just never going to work.
But it's so hypocritical as well, because take, for instance, a medication like gabapentin.
Mm-hmm.
Physicians use it all the time here in North America, same in the UK.
Yeah.
Right? And the knock on cannabinoids, not enough evidence.
Mm.
Well, when you look at gabapentin, there's no evidence to suggest it's useful in chronic pain. In fact, there's a JAMA article saying clinicians should tell their patients that when prescribing, this is off-label use. So it's kind of this double standard that exists, and if you apply the kind of common sense knowledge to chronic pain in cannabis, there is a ton of research suggesting there's benefits, and then clinically, of course there is, and we're often able to reduce opiates as well. But there's always this double standard, even as far as evidence goes.
Yeah, absolutely. I use the gabapentin example a lot because, everybody knows everyone who's on gabapentin for a bad back. I'm like, there's never been an RCT for gabapentin and a bad back. So what are we doing?
Yeah.
It's completely ridiculous. But in terms of, because you've done a lot of work around opioid reduction, and I thought it was interesting what's happening in the UK at the moment, because NICE have said quite recently that they no longer recommend opiates for chronic pain.
Right.
So that means that everybody in the country who's on opiates for chronic pain are going to be getting the call to wean them off, and there is no alternative offered.
Right.
And obviously, as somebody with a history of chronic pain who's treating really successfully with cannabis, I'm thinking, God, there's got to be an in there for cannabis.
Yeah, it is a no-brainer.
Yeah. And you've seen, and have you seen really good results in terms of weaning off opioids with cannabis?
In some patients, so that is the truth. Certainly, some patients start on cannabis that are on opiates and may not come off. That's a reality too.
Yeah.
But no doubt with what's going on with the opiate crisis, same guidelines here. Like we're under guidance to lower our morphine equivalents.
Okay.
And there's a pool of non-opiate options that are recommended. So you have your gabapentin for some reason, your pregabalin, your antidepressants like duloxetine, which again is off-label use for chronic pain with very limited evidence, some that it's helpful. But here, part of the Health Quality Ontario guidelines for non-opiate options, cannabinoid-based medicines are in there as well.
Right.
So you have this collection of options, and the physicians in the UK will same thing. You're going to have to stop using opiates for chronic pain and use these options. And then out of those options, it's very easy to write the script for gabapentin, pregabalin, but the other option, cannabinoid-based medicine, is not getting utilized because, again, that gap between comfort, education, bias, stigma, practice logistics, it might take a little more time. I'm sure it would in the UK as well to actually write that first cannabis prescription. So although it makes logical sense, especially when you compare it to the other options that are being offered, the duloxetine, the gabapentin, cannabinoid-based medicine is right there. It's just, it'll never be kind of top of mind or until the rules kind of change and it becomes easier to do, which is unfortunate because a ton of people benefit. And sorry, I forgot to kind of touch on the opiate sparing effect, but yes, in practice, that happens all the time. I'll get referrals for that. And what often is the issue isn't the efficacy of cannabinoids. Patients will do great. They'll reduce their morphine equivalents. Cost. So it's much more affordable here in Canada compared to the UK, but still, a lot of these patients are on disability and are on government assistance. So when they have the option of their opiate, their Percocet, their hydromorphone, which is covered, versus switching to something like a cannabinoid-based medicine and paying out of pocket for it, so basically pay for my medication or groceries, they're going to stay on the opiate because it's covered.
Yeah, totally.
So you're battling a lot of things.
Yeah, and I suppose that's what's happening here. But with access to private prescriptions being costly, people are already choosing between their medicine from the illicit market at £10 a gram and shopping. That's the reality. And so to try and criminalize them for that instead of choosing something that they absolutely can't afford, it just doesn't make any sense to criminalize them based on the fact that they're taking a medicine that's helping them and that is keeping them off fentanyl and morphine and drugs with, let's face it, a risk of death.
Yeah, it's insane. It's insane. It really is. And especially too, because, part of the opiate crisis is then, you go from that prescription to injecting things, right, to overdose, to death. And again, on the cannabinoid side of things, it's not a possibility. You don't see that. So just from a harm reduction standpoint, it makes a lot of good sense, let alone it is efficacious. It has fewer side effects. So there's a number of reasons why it makes sense. Yeah,
totally. Do you think, have you seen throughout your practice the stigma change? Because I suppose all of the things that we're talking about, there's, the issues, the roadblocks, the issues that are still existing in Canada, the issues that are rife in the UK, it's all based on, really inherent sort of archaic stigma that we've since sort of disproved with science, but people are still of that mind. Have you seen a shift?
I have for sure, especially in more so in the patient population,
right,
which is interesting. And for physicians, it's imperative to continue learning, to continue adapting, right? Follow the research and be current. And whereas now with information being so readily accessible, patients are advocating for themselves, and actually kind of, in a lot of the cases, if a physician chooses to keep their head in the sand, uh, they're at risk at looking pretty silly when their patient is so informed. So I'm seeing that the patients on the stigma side is reducing, especially, sure, our age group, right? Yes, minimal stigma, but where it's very obvious that that's changing is in the senior population.
Right.
Yeah,
Yeah. 'Cause
and
you treat a lot of those patients, don't you?
yeah,
And
definitely.
have they been more open to it recently? That conversation,
Yeah, within the last couple of years,
right?
and I think kind of legalization here really, even though it was medically legal for a long time now, but I think with just being kind of full legal across the board, it's really opened up that dialogue. Um, Not that adult use is the same as cannabinoid medicine, but at least, that conversation's out there. But they're definitely, we're talking 70, 80-year-old men and women who never would have even thought about it, but now are getting the referrals or talking to their GPs to get the referrals. So it's definitely changing, and it makes sense for that particular patient population, because what's a big issue with those seniors is the amount of drugs are already on.
Yeah.
So the other benefit, and I know this is obviously a very pro conversation, but it's true. The other benefit is oftentimes we treat these seniors with a cannabinoid medicine, and they're on something for sleep, like a benzo or Ambien or Zolpidem. So that goes away. They're on something for their anxiety or depression, like an SSRI. So that goes away. They're often on something for their pain, like a gabapentin or an opiate. That goes away. So you're often able to reduce the amount of polypharmacy and lower their risk of adverse drug to drug interactions.
Hmm. Yeah, for sure. And I don't think that just applies either to if thinking about the amount of drugs, I've come off like 23 drugs and replaced it with one.
Yeah.
And it's just, every time I think about that, and, I've had the big boxes out for on the table for the news, and, they like
Yeah.
to film it. And then I go, oh, and they've replaced it with this, just
Yeah.
as cannabis bud. I think that polypharmacy, I think it's probably more rife in the elderly population, but for chronic pain patients, obviously, you get lobbed on the standard stuff, and then you escalate through the opiates as
Yeah.
they sort of wear off. And before you know it, you're covered in fentanyl patches, and you're off your face on drugs all the time.
Yeah.
which
Yeah.
is a huge issue, and a real life changing thing for me. And what I'm seeing in the chronic pain community is the ability to relinquish all of that for one thing that does the job of many, and also stops those drug interactions and those side effects. Because sometimes I guess you get to the point as a patient where you don't know what's the side effect and what's the
Well,
illness.
it gets very blurry, and I see patients like that all the time. They'll be, on a number of different medications, and one of my kind of routine questions is, well, does it help? Because I ask the same thing anytime I start somebody when we have our follow-up in a month or two. It sounds very simple, but is this helping you? Has it been effective? Right? And when you ask them about the meds they're already on, they'll a lot of the chronic pain patients will get into this realm of, I don't know anymore. I take these things because I was told to, and I was never weaned off when it didn't work. It was just, okay, add this
Add
in.
some more, yeah.
Yeah. So they really don't even know why they're taking things, what's helping, what's not. And again, once we start, and if we do see improvement, then oftentimes the goal for a lot of patients is to come off of the things that they have no clue what they're doing for them.
Absolutely. Do you have any advice for patients who want to talk to their doctor about how much cannabis is helping them?
Yeah. So it seems silly to say, but right away my brain went to basically kind of bring up the conversation delicately.
Mm-hmm.
Um, not really kind of in your face, or I need this, like, collaborate. But the truth is, sometimes it can just be a flat out no, unfortunately. So rather than get into it with your physician because of their views, potentially older dated views, bring it up, be collaborative, bring your research, be well versed. But if, and this is going to happen to a lot of people, if that physician or nurse practitioner isn't receptive, then move on. Advocate for yourself. There are more and more physicians in the UK getting comfortable with things. So just move on. You're entitled to a second opinion, meeting with another physician who might have a different view, because at the end of the day, that's really what it is. It's that particular physician's view on this subject. And there are other physicians that have different views. So seek out someone who will have that conversation.
Yeah, that's really, really helpful. We were thinking, because obviously the project that I launched, CanCard, is a card to stop people from getting arrested, quite simply, for possession. If they qualify for prescription and they can't afford it, we've worked with police to say, actually, those people you shouldn't really be arresting them or kicking the door down, because actually they just can't afford the legal route, right?
Yes.
And so we're thinking about other things and other ways we can evolve to help patients advocate for themselves, to empower them, but also to provide an evidence base. So we were thinking about, evolving the app into like a do your own observational trial sort of thing, where the patient reports what they're consuming, how they're consuming it, how much it's helping, and then they can produce their own report to show doctors that, okay, so this is the results I'm seeing symptomatically.
Yeah, we need a lot of things to change though in the UK. Like the work you're doing is amazing, and I think there has to be something going on behind the scenes where the current system where two specialists need to agree that this is a reasonable treatment option is ridiculous in my mind. The GPs, of course, should be able to recommend this medicine because they're the ones seeing chronic pain patients, sleep disorders, mental health. And then in my case, even the dementia residents as well. So getting away from that two specialist system needs to go. GPs need to be able to prescribe, and then it needs to be affordable, because what you were mentioning with how many quid it cost you is insane to do it the legal way. So there's a lot of things that have to change before we'll probably start to see any real traction in the UK.
Yeah, for sure. Yeah. Hopefully hopefully it won't take too long, because, there are a lot of people who, who are poorly and are living in fear of, social services and the police and stuff just for taking a medicine that helps them. And that's something that I personally can't stand by, particularly when we're surrounded by, the other countries that are like, actually, yeah, no, this stuff works. So maybe get on with it, kind of thing.
Seriously. And then to the coverage side of things here, like it's still, at least it's a little more affordable here.
Yeah, actually, we haven't talked about that. So you're running a new campaign. It's called Cannabis. Cover Cannabis, is it?
Cover Cannabis.
Very cool.
Yeah, and that is like,
tell us a bit about that.
Sure. Like, so here, it's much more reasonable. All right. Let's say if I'm working with a patient, let's say a chronic back pain patient is on a CBD dominant formulation, I don't know, 10 milligrams twice a day, that might cost them $70 to $80 a month, which is fairly reasonable. Mm-hmm. But again, when other things are covered, and obviously with everything pandemic, and a lot of these patients are lower income patients, that's still a massive amount when something should be covered, especially with dementia residents or vulnerable populations. Yeah. So the whole Cover Cannabis movement that we're trying to create is just awareness around that. So I'm doing a lot of patient interviews and telling the stories, and tagging members of parliament, provincial parliament, insurance companies. But basically the idea is we're not going to have the pharmacoeconomic data to do this. Like, it's just not going to happen. We need grassroots. Here are the stories, here are the people, and put it right in front of the people who make these decisions, to the point where it becomes undeniable that this needs to be covered. So that's kind of the idea with that.
You're amazing. You're like a patient advocacy activist doctor. I love it. Like,
well,
you've just,
thank you.
championing. And, you know, I'm sure the patients who eventually, when you get it over the line, will, you know, it'll make a massive difference to their lives, because access is a real issue.
Yes,
and you're doing a brilliant job.
Thank you. And when that happens, not if, when it happens, it'll definitely be cause for celebration, for sure.
Yeah, absolutely. That actually brings me nicely onto my last question, which was, if you had a magic wand and you could fix everything to do with cannabis in Canada, and access could be however you want it to be, what would it look like?
Well, I would, being a realist, I would say, because I've got
it. I mean, it is a magic wand, so you can be.
Oh, true.
Yeah, it's magic. So
I forgot. So the little baby step with the magic wand would be to honestly to start with. It makes no sense that the vulnerable patient populations don't have coverage. So that would be the first thing with the magic wand. Would say all these kiddos with the rare epilepsy syndromes, the severe autism, developmental delays, and then conversely, the dementia patients with the responsive behaviors who were weaning off the antipsychotics, those vulnerable populations first need coverage. And I think there's a very reasonable way to do that. We have special use codes we use, same thing in really any, whether it's UK or Australia, different special access schemes. Mm-hmm. So if the patient has a qualifying diagnosis, coverage, you know, a certain amount, a reasonable amount. But that would be, if I had the magic wand, it would be coverage for the vulnerable populations, then coverage for seniors, because they are the ones who are really benefiting. And then as far as now that I've got this magic wand going, then I would mandate cannabinoid education into the core curriculum of medical school, so that we have students learning this isn't just a drug of abuse, right? There are legitimate medical reasons for using this, and teach them about the endocannabinoid system. And then lastly, with the magic wand, some type of mandatory training for current physicians to, at the very least, get educated on it. Maybe they won't adopt it into practice, because that's everybody's individual right. As a clinician, you practice how you want, but you at least need to know the basics to have the conversations.
I love it. I mean, they sound like quite sensible small steps, but actually, if you think about the impact of that for a patient going to their GP, just to be able to just have that conversation is, you know, is going to make a huge difference. So I like it. I like what you've done with that one. Amazing. Okay, I'm going to stop the recording there. Thank you so much, Blake, for having a chat. It's been awesome. Really nice to have you on. Good luck with the project.
Thank you. My pleasure.
Right.
Take care.
Take care. Bye.